Good morning, everyone. Today's case is a 3 year, 6 month old child, Master Mohammed Farhan Islam Sadiq, hailing from Bangladesh. Informant is mother, whose history is reliable. Mother gives chief complaints of recurrent respiratory tract infection since birth. History of presenting illness: child has recurrent respiratory tract infections of about 4 to 5 episodes per year. Mother gives history of poor weight gain, history of forehead sweating while feeding, no history of bluish discoloration. Child was diagnosed with pneumonia at the age of 8 months and was admitted in a hospital for 7 days and was treated with IV antibiotics in Bangladesh. On evaluation at that time, he was diagnosed with a congenital heart defect and was on regular follow-up since then. Child is on syrup furosemide 2.5 ml OD, tab spironolactone 1/3 tab of 25 mg and tab ambrisentan 5 mg since 8 months of age. Mother's antenatal history is uneventful. He's a only child born with cesarean section, the indication being a big baby. The birth weight was 4.5 kg. The child had no NICU admission. The baby was breastfed for 6 months. The developmental milestones were achieved appropriately for age. Immunization history was up to age. Now the child consumes a non-vegetarian diet. There's no other relevant family history.
When exactly the symptoms started?
So the child had a RTI, but on 8 months of age he was diagnosed because he was admitted in hospital.
And any other symptoms?
Other than that, only mother gives history of decreased appetite and poor weight gain.
In an infant, what are the symptoms of left heart failure?
Sir, forehead sweating, history of suck cycle.
Don't say that first. First is not forehead. Forehead sweating comes later in the.
So, failure to thrive, refusal of feeds.
Not exactly the correct way the examiners want you to present. First is the feeding difficulties, tachypnea, tachycardia, and feeding difficulties. And what do you mean by feeding difficulties? That should be the, and you first say the feeding difficulties, then you say the suck cycle. Because in an infant, the breast sucking needs a lot of effort. So they go in. The first sign of left heart failure in babies, tachypnea, tachycardia, and uh, feeding difficulty, which is actually the suckling cycle. Then comes the forehead sweating, all those things.
Yes, sir.
And then usually in a moderate sized BSD, what time after birth the symptoms start?
So after 4 weeks of age.
6 to 8 days. Why is that?
So, because they do not cause.
Very large BSDs may be symptomatic. Others, 6 to 8 weeks, they start these symptoms of left heart failure. Why is that?
As the initial first few weeks, there is a drop in pulmonary vascular resistance.
Yeah. Say the other way. Initially, there's a high pulmonary vascular resistance. The flow to the pulmonary arteries is not very high. So most
Yes,
of
sir.
the symptoms are due to very high pulmonary outflow and into the LA, increase overload of the LA and LV, and the LV goes into failure, which produces the symptoms of tachypnea, tachycardia. And then as the child grows, you say failure to thrive. What exactly do you mean by failure to thrive?
So that higher demands, metabolic demands and fatigue, which occurs with feeding, which leads to decreased weight gain.
Yeah. And also because of the left to right shunt, relatively most of the blood goes into the right side, and the
Right side of
relatively so failure to thrive, and that usually manifests as a failure to gain weight rather than failure to gain height. So usually the weight can be less than 30% as of now. So that's exactly what. Okay, all right. So
yes.
okay. And actually, we have described many, even 2 weeks ago, what exactly is the definition of a repeated respiratory tract infection. What we mean is a repeated lower respiratory tract infection. They may get frequent upper respiratory, but what we mean, and I explained the reasons for that also last time. Okay.
Yes, sir.
And the Indian Association of Pediatrics define it as more than 2 or 3 in the last 6 months. Okay.
Months.
And usually require antibiotics, sometimes hospital admission.
Yes, sir.
Yeah, okay. These are basic things to right.
Yes, sir. On general physical examination, the child is conscious oriented, the child is cooperative, afebrile, there's no pala, no icterus, no cyanosis, no clubbing, no pedal edema, or no generalized lymphadenopathy.
Okay.
The pulse rate is 104 per minute, regular in rhythm, normal volume, with no radial or radiofemoral delay. All peripheral pulses are palpable. The blood pressure is 100 by 64 mm of mercury, which is measured in right upper limb in sitting position. The respiratory rate is 24 per minute, abdominothoracic type of respiration. Saturation is 99% at room air, then JVP is not raised. Systemic examination, cardiovascular system. On inspection, apical impulse is seen in left sixth intercostal space, half-inch lateral to mid-clavicular line. There is no scars.
You can see that, is it?
Yes, sir, it is seen.
I told you many times, how can you say 6 space without actually the measuring the intercostal space starting from the angle of the APN? So normally we describe apex
Lower and
visible
below the
in the
nipple.
mid-clavicular line, in the mid-clavicular line, in the anterior axillary line, below the nipple. Only that description you can give on inspection. Unless it's a very marasmic child, you can count the ribs from outside, but that's not the correct thing to do. So you say whether it is the mid-clavicular, outside the clavicular, anterior axillary, even mid-axillary line or something, what it is. So don't say the 6 space, okay?
Yes, sir.
That in your palpation it comes. Then the reference point is the angle of Louis. From there you measure.
Okay, sir. Okay.
Then what else? Go on.
Yes, sir. On palpation, apical impulse is confirmed to be in left sixth space, half-inch lateral to mid-clavicular line, hyperdynamic in character. Thrill is appreciated along the left lower sternal border. There is no palpable heart sound or parasternal heave, no palpable pulsation over the chest.
No thrill. Okay.
Yes.
There's a thrill, is it?
Yes, sir, there's a thrill.
Okay. Then you should specify which space is the thrill.
Yes, it's the lower left sternal border,
Okay.
around the fifth space.
That gives you some idea of where exactly the VSD is located. Okay.
Okay, sir. On auscultation, S1, S2 is normal. There's a holosystolic murmur here along the left lower sternal border of grade 5/6. It's radiating over the entire precordium. No other murmurs here.
What other murmur did you look for?
So there is in the pulmonary area an ejection murmur.
Yeah.
Or in a relative in a mitral area low pitched diastolic murmur.
Apical mid-diastolic murmur.
Yes.
What does that mean? What is it? What is the significance of a mid-diastolic murmur in the apical area?
It's then which means the shunt is large, so there's increased flow from left atrium to left ventricle.
Usually it says shunt is more than 2:1. Then only the pulmonary flow is 2 and the systemic flow ratio is 2:1 or more. Only apical diastolic murmur appear. In
Yes.
ALD, where is the flow murmur?
Along tricuspid area.
In the tricuspid area. Okay. Is the P2 accentuated or not?
Sir, no, sir.
It is not accentuated. Then respiratory system 24 per minute.
Yes, sir. 24 per minute.
Is the child obviously tachypneic or
No,
struggling
sir.
for
It's comfortable only.
breath?
Comfortable.
And the other systems are normal.
Yes, sir. Other systems are normal.
No abdomen, no evidence of liver or enlargement. Okay. So what's
Yes.
your diagnosis in this case?
Acyanotic heart disease, the shunting at the ventricular level, sinus rhythm with signs of CCF on treatment, with no signs of pulmonary arterial hypertension or thromboembolism or infectoendocarditis.
Okay. What the treatment the child is on?
So child is on diuretics, on Lasix and spironolactone. And started on ambrisentan also.
What is that?
So that is for they've given for PH.
You said there is no the pulmonary second sound is not accentuated.
It's not, yeah, clinically it is not there.
What is the normal treatment of a left heart failure in a small child?
So diuretics, beta blocker.
Mainly usually it's diuretics. And diuretics also in babies, if you give Lasix, there's a problem of potassium going up,
Yes, sir.
So that's why you give spironolactone also, okay?
Yes, sir.
And the next treatment in such cases is a afterload reduction by ACE inhibitor.
Yes, sir.
And the problem with ACE inhibitors is that ACE inhibitors themselves increase the potassium level of the body. So if the patient is on ACE inhibitors also, you don't combine spironolactone,
Yes, sir.
which conserves potassium.
Potassium
Also, you
spike.
don't supplement potassium in such cases.
Yes, sir.
You know what to do. So,
So,
how do you know it's a small, moderate, or large VSD? Of course, that is explained only after an echocardiography, but the examiners are very fond of asking what's the difference of a small VSD, what's the difference of a moderate VSD, what's the difference of a large VSD.
So, large holosystolic murmur, and the baby presented in
Saying the symptoms. I'm asking the definition of a large VSD, definition of a moderate size VSD, and definition of a small VSD.
sir, large VST. They have identical right ventricular and left ventricular systolic pressures. They both are elevated.
Normally, what the answer should be, the large VSD is the same diameter as the aortic canal. That's the first thing to say.
Yeah,
Or
okay.
more than 75%.
75% of the aortic annulus.
Because the babies may be of a different size. So 3 millimeter a BSD in an infant of 2.5 kilograms is more significant. So that's why you always connect it to the aortic annulus diameter.
Diameter of 75% of more of aortic annulus is large.
Yes,
Small is less than 33%. Moderate is diameter of 33 to 75% of aortic annulus.
Very good.
Then, yes, sir. Then by echo wise, the flow velocity in a large defect will be less than 1 meter per second.
Very good. Yeah.
The small defect will be more than 4 meter per second. Moderate will be 1 to 4 meter.
Very good. And the pressures? The pressure is equalization of the pressure.
Equalization of both the left ventricle and right.
And the pulmonary artery pressure is also at the systemic level. In a moderate VSD, the pressure is defined as either normal or up to 2/3 of the systemic pressure. Okay. In a small VSD, the pulmonary artery pressure is normal.
Normal. Okay.
And the other thing is that smaller VSDs make harsher murmur. Very large VSDs may not produce a murmur like a tetralogy of Fallot. In tetralogy of Fallot, the murmur is not from the VSD, it's from the pulmonary stenosis.
Pulmonary artery.
Very specific manner. And then the flow murmur and the evidence of accentuated P2. This gives you an impression where there is a small moderator with large ventricular septal defect. Okay, all right.
Yes, sir. I would like to further investigate
common associated features of VSD.
Associated of VSD. PDA, sir. 25%. Coarctation of aorta.
PDA 25% is very high. Usually 6 to 8%. Coarctation about 10%.
10%.
What else?
Aortic stenosis, subvalvular or valvular aortic stenosis.
More than subaortic membranous stenosis, SAM. Okay?
Yes, sir.
Maybe present in 2 to 3%. Usually it's not aortic valve stenosis, but can occur. Okay.
Infundibular stenosis or pulmonary valvular stenosis.
And that's one way of Gazou's effect, one way of reducing the shunt actually. Okay.
Yes.
Then they are interested in asking you, what is the incidence of VSD among congenital heart disease, and what is your impression about spontaneous closure of VSD? What will your answer be?
So approximately 30 to 40% of patients with muscular VSD or membranous VSD have spontaneous closure within the first 6 months of life.
Now, first say the incidence of VSD and the natural history of VSD.
So the natural history is about 30% of infants with severe symptoms such as congestive heart failure or failure to thrive will require surgery within 1 year of life.
In VSD is one of the most common congenital heart disease, which is about 25 to 30% of all congenital heart disease, except the abnormality of a bicuspid aortic valve, which is more than that. Okay, that's what you should have. Then, what's the natural history?
Yes, so about 30% of infants with congestive heart failure will require surgery within 1 year of life.
But normally we say about 10% of the VSDs, rare VSDs, die of left heart failure in the first year. So the survival of a VSD at the end of 1 year is only 90%, 10%. Then what do you mean by spontaneous closure? Where does it occur? Where it doesn't occur? And what is the reasons?
Spontaneous closure occurs in muscular VSDs. The malaligned VSD or inlet type of VSD is unlikely to close spontaneously.
Good.
And it occurs by overgrowth of nearby tissue or a septal or the septal leaflet of tricuspid valve or RCC or NCC prolapsing or aneurysm of interventricular septum.
Not interventricular septum, the membranous septum. Okay. Not the whole interventricular septum doesn't never become aneurysm.
Okay.
Normally, actually, you answered correctly in the first instance. Taken all VSDs together, 30 to 40% of VSDs may have spontaneous flow.
Spontaneous closure.
Even larger VSDs become smaller, about 25% become smaller in size. And also it depends on the time you see, because nowadays echo is done so frequently. Classical description is that if you see a baby at 1 month, there's an 80% chance of that VSD closing. Moderate size VSD, not very large. And if you see at 3 months, 60% of them are likely to close. And if you see at the end of 1 year, about 25% of them may close. And normally VSDs usually close by 3 to 5 years. Because small VSDs may close even later. But usually maximum closure occurs in the first 3 to 5 years. So these are some of the facts you should know during an exam. And the mechanism of closure you mentioned, but little more.
Yes, sir.
What exactly do you mean by a malaligned VSD?
Malaligned conoventricular VSDs.
Huh?
So malalignment or anterior or posterior malalignment or rotational malalignment.
Malalignment of what?
Of the septum, interventricular septum to the outlet. I mean, of the malalignment of the conal septum.
The infundibulum septum conal. So normally in the development congenital heart disease, I mean not normal embryology, the infundibulum septum comes down and closest to the trabecular septum marginalis, between these two limbs, the posteromedial and anterolateral and the body of the trabecular septum marginalis, the infundibulum septum or conal septum comes and closes to the trabecular septum marginalis. In patients with pathology of Faro, this is anterior
Anterior malalignment.
deferred non-alignment, so much so that VSD as the child grows becomes bigger and bigger. So that's why such VSDs never close.
Okay.
The maximum closure, as you said, is in the muscular or trabecular VSD. Then comes the trabecular VSD because of the as the child grows, hypertrophy of the trabecular and then the close. Okay. And perimembranous VSD is also likely to close. And that mechanism you should know thoroughly.
Yes, sir.
Yeah. It's closed by usually the adherence of the septal leaflet of the tricuspid valve to the lower part of the VSD, or hypertrophy of the chordae tendineae of the septal leaflet, and they are joining together and so trying to reduce or even close the VSD. The other is aneurysm of the membranous septum of the membranous septum, which is closer. And the last thing some of the textbooks say, after a bacterial endocarditis, education, I don't know how true it is, I close the VSD. Okay, I treated
Endocarditis.
endocarditis. So these are the things mentioned. And what happens if the septal leaflet gets adherent to the lower part of the margin of the VSD? What happens? It may lead to a Garbodi shunt.
Right. Yes, sir.
You know what is a Garbodi shunt?
So it's shunting from LV to RA.
Good. Why? What's the reason for that? If you say good echocardiography, you always find that attachment of the leaflet of the mitral valve is at a higher level than attachment of the septal leaflet of the tricuspid valve. So there's a gap there. And that gap, because that's directly in connection with the trichytia, because the septal leaflet of the tricuspid valve is a lower level, that is very clearly seen in all echocardiography. So much so, what is known as the atrial ventricular septum. There's a small area. Through that, if there's a hole there, it produces a. Similarly, the septal leaflet of the tricuspid valve also becomes adherent to the lower part of the margin of the VSD. That also produces the same effect. There is a shunt direct ventricle to the right atrium. So these are the things you should know. Mechanism of closure, how often the closure, the natural history.
Yes, sir.
Then what are you going to do? This patient is symptomatic. He's on diuretics to control his heart failure. So
Yes, sir.
you have to
So
investigate.
further to confirm the diagnosis and see for any associated defect.
To confirm the diagnosis and to decide on the treatment and decide on the timing of surgery. Because in these cases, the timing is very important when you want to operate. All these things you can identify by doing some investigation. So first, what?
Yes, sir.
What
It's a ECG.
Yeah.
Yes, sir. It's a 12-lead standardized ECG.
Yeah.
With a rate of 108 per minute. A normal sinus rhythm.
Yeah.
The normal axis.
What about P wave? Is there any evidence? What is the transactional signs of VSD?
Sorry, sir. I can.
What are the classical ECG signs of VSD?
A large VSD will have a biventricular hypertrophy.
That's moderate VSD. But that's
Moderate
one sign.
has a left ventricular
Increased volume. So left atrium, there's increased volume in the left atrium. They should by LAE, left atrial enlargement, and left ventricular hypertrophy. These are the classical signs of a VSD. Left ventricular volume overload also. So something like P mitral, biphasic in V1. Then evidence of large flow in lateral chest leads. What is that?
Sorry, evidence of?
High flow, left to right shunt. A QA, that's a sign of a large flow. When the Q waves are present in the lateral chest leads, it's a sign of a high volume in the left ventricle and left ventricular hypertrophy. And as a patient develops pulmonary hypertension, you get a biventricular hypertrophy. What is the ECG factor in a biventricular hypertrophy?
So this for LVH, the Sokolov lines criteria is satisfied, and for RVH, the RS pattern R by S ratio is more than 1.
Have you heard of what cardiologists say, Katz-Wechsler phenomenon? Have you heard of it?
It's a yes, biphasic QRS complexes in V2 to V5.
The R and S in the mid-precordial leads are of the same amplitude.
Yes, biphasic complex.
The Q wave disappears. In this pulmonary hypertension, the Q wave disappears also.
Yes, sir.
So I can't read this anyway. What is in this case? Are there Q waves in the lateral? Q waves are in chest. That's
No, sir, it's not.
I think maybe suggestion of a Q wave. I can't see it very well. And the axis. What are the axes of usual VSDs?
Usually normal if any associated pulmonary arterial hypertension or right axis deviation.
What about another type of VSD, which may not have right axis deviation, but a left axis deviation?
That in AVCD.
Maybe canal type of defect, or
Yes.
what you call as a posterior paratricuspid inlet defect. In that type, it's a left axis deviation, like an AV canal.
Yes, sir.
And actually, such VSDs do not close. We mentioned many other VSDs which close, and you said the subpulmonic VSDs may close. Subpulmonic by the prolapse of the
Aortic.
right coronary cusp, and the perimembranous defect by the prolapse
Tricuspid.
of non-coronary cusp. Actually,
Yes.
non usually. And what the reason for prolapse?
Venturi effect.
Yeah, because it's usually very small VSDs. There's a very high velocity, as you
And a
mentioned,
decreased pressure.
4 meters per second. So it produces a venturi, and the overhanging coronary cusp prolapses into that. Okay, got it.
Yes.
At what age does it become manifest, the prolapse of the coronary cusp? Usually they say in 5% by the age of 5.
So the age of?
5 years usually.
Okay.
Not in about 5% of the VSDs, the subpulmonic, and in lesser percentage of the perimembranous VSD. We prolapse of the cusp in small VSDs. Okay. So what else? What is the test now?
Yes, sir. Next is the chest X-ray.
Very good.
Yes, sir. It's a well centralized, well exposed X-ray. Site is
Slightly
solid.
rotate.
Mm.
Slightly rotate.
The babies, yes, sir.
Yeah. Okay. All right.
PA view, chest X-ray PA view.
Yeah.
Levocardia, cardiomegaly present.
Yeah.
Yes, sir. The aortic knuckle is small. The PA is dilated.
First, when you say cardiomegaly, they expect you to say it's 60%, 55% or something. The examiner is supposed to say that. Okay.
Yes, sir. 70.7 cardiothoracic ratio.
It may not be that much. Anyway, it's about 60%. You know how to measure they say, you know how to measure it.
Yes, sir.
The midline from the right side and the left
On
side.
the left side.
You draw midline and maximum on the right side enlargement to the midline plus maximum on the left side to the midline. These two together is the cardiomegaly.
Then pulmonary PA is dilated.
The important thing is to say whether the patterns of left ventricular type or whether
type
the
of
left ventricular enlargement, left atrial enlargement.
Yes, LV type of apex.
Yeah.
And the lungs are plethoric with prominent hilar shadows. CP angles are normal.
Okay. All right. So it fits in with a fairly large VSD with a good flow. No evidence of pruning to show that it's a pruning is there. We know it's a severe pulmonary vascular disease. Doesn't show that.
Yes, sir.
Aorta. What the importance of aorta in shunts, left to right shunts?
If it is prominent, to know whether it's associated with PDA.
PDA or AP window is usually much larger.
Yes, sir.
Much enlarged. In ALD, it's very small, and in
VST is also.
This fits in with probably a ventricular septal defect, because
Yes.
the type in the atrial septal defect, there is a left ventricular type of apex, left atrial enlargement, and then
Yes.
plethora in there. Okay. So what next?
Next, transthoracic echo.
Yeah.
Yes, sir. It shows levocardia, a large perimembranous VST with upper muscular extension, which is partially restricted by right coronary cusp prolapse, the left to right shunt. and the defect is about 10 mm, and the gradient across it is 48 millimeter of mercury. Then there is an associated small ostium segmentum AST, which is a left to right shunt. The small discrete subbiotic membrane. Then the RCC and NCC prolapse with a trivial AR. There is no LVOT obstruction. A grade 2 MR. There is also an RVOT muscle bundle with no significant RVOT obstruction. The gradient is around 29 millimeter of mercury with a good biventricular function.
Okay. So
A mild
is it
pH.
operable? Is it operable? Mild pH. Okay. All right.
Mild pH. Yes, operable.
So what else do you need before you decide that on surgery?
Sir, since it's mild pH, we don't need a cath also.
Yes. No need. That's what should say. Cath is indicated when you suspect that the flow is less, there's pulmonary hypertension, pulmonary vascular disease, no evidence of a large VSD with a shunt. Good, if the good shunt, then it is no need to go ahead with catheterization. Symptomatically, what happens when a patient with a large VSD develops pulmonary vascular disease? What are the symptoms and what are the X-ray signs to differentiate between a patient who is developing pulmonary vascular disease and a VSD with a large flow? The first thing is the parents say the child is better now because
Yeah.
the repeated respiratory infection, everything is gone now
Yeah.
because of the pulmonary vascular disease. The flow has become less. The child is less symptomatic. So even the child has become more sick, the parents feel that he is feeling better.
Yes,
And
sir.
you take a chest X-ray. Previously, there is a cardiomegaly and the things. Usually, the heart size becomes smaller because the left ventricular volume overload is not there. So the CT ratio becomes less and it looks apparently better. So actually, it is not. The sign of development of severe pulmonary vascular disease.
Yes, sir.
Doubtful cases only you do catheterization to measure the pulmonary vascular resistance, actual pulmonary. In the others with echo and Doppler.
Yes, sir.
Doppler gives the pressure in the shunt, all those things we can calculate. So what are you going to do? Good.
So we'll suggest him to undergo surgical closure of VSD.
Yeah. What about is a trivial? There's some little prolapse and trivial AR.
Yes, sir. Yeah, the subaortic membrane will excise. The trivial AR we don't have to address. It's an indication, and the prolapse is an indication to close the VSD.
Did you say there is subaortic membrane? I thought you said infundibulous stenosis. Isn't it? No. There is subaortic membrane also, is it?
It's a small membrane, sir. No LVOT obstruction.
SAM is seen in about 2 to 3% of cases of VSD.
Yes, sir.
But in this condition, you may get a more significant subaortic membrane. After certain operations, the incidence of subaortic membrane is very high. What operation?
So what?
Previously, they used to be a banding. For some reason, a patient with a PA band has got a higher tendency of developing a subiotic stenosis. Okay. And actually, the textbooks are not very clear what exactly is the reason, but they're finding that a patient with a PA band, certain percentage, I don't know how much, develops subiotic. Then the question they ask, what exactly the timing of surgery is equal? You understood my question, you know?
The timing of surgery.
Yeah.
So a large VST we close within 1 year of life. Large symptomatic VST.
What I expected is that a large VSD in a child less than 3 months with symptoms of left heart failure, not well controlled with medication, should be closed as early as possible. Okay. A child with a large VSD with symptoms, but can be controlled with medication, should be closed at the age of 6 months. This is actually, I told you many times, read the recommendations by the Indian cardiologists and cardiac surgeons. Should be closed by 6 months. And they also say if a patient is absolutely asymptomatic, no pulmonary hypertension, moderate BSD, it goes by 3 to 4 years. But in this hospital, the usual practice is to close it by 1 to 2 years. Normally, previously we used to teach them if a patient is asymptomatic, no pulmonary hypertension, it's usually closed before the school going age, but now they go to kindergarten at an earlier age, you know. So in this hospital, the policy is to close it at 1 to 2 years. A patient with a moderate size VSD. Small VSD need not be closed.
Closed.
But there's some exceptions to small VSD.
Any like a aortic valve prolapse.
Yes. Prolapse or AR.
Yes.
Prolapse alone is prolapse alone an indication for closure. Some people think in the subpulmonic VSD, this is the opinion of several cardiac surgeons, better close with a small patch that it gives support to the cusp and also it takes off the venturi effect so that it doesn't collapse anymore. But in a perimembranous VSD, with prolapse of the non-coronary cusp, usually they say if there's development of AR, close with that time. And severe AR and all, they don't need any special repair technique.
Valve repair or
reset. If it's a moderate AR, they need either
resuspension.
Transverse or not resuspension. Transverse repair or Jacob's repair. Okay. That we've discussed a few times earlier. So in this case, it's 3 years, 6 months, you know. First, ideal time should have closed probably early. Time to close. What are the routes for closure of BSD?
Routes, sir.
Surgical.
So for this perimembranous through RA, transatrial.
Most of the BSDs are closed right atrial. Even Some muscular VSDs can be caused through the right atrium.
Yes, sir.
What are the types of muscular VSD?
Sorry, sir.
What are the types? What's the incidence VSD in different sites, and what are the types of muscular VSD?
So 70% is perimembranous,
Yeah.
20% is
80%.
muscular,
Huh?
20% muscular, 5% is inlet.
5 to 20% is actually yeah.
Yes, sir. And 5% is inlet and outlet VSD.
Is there any difference in the incidence of outlet or subpulmonic VSD between the Asiatic group and between the European statistics?
Yeah, European it is more certain, 30%.
No, it's the other way. In Europe and all, the subpulmonic VSD is supposed to be 5%. In the Asiatic, mainly statistics from Japan and China, it's up to 30%. Then there is subpulmonic VSD. Even in the tetralogy in this area, the tetralogy actually basically a perimembranous VSD with extension into the muscular part, one type, paratracheal posterior or the AV canal type of tetralogy, or in the subpulmonic area. Okay? And that's very common in the Asian countries. So what are you going to do in this case?
Yes, so we'll offer surgical closure.
Yeah. Probably this case will need only a VSD closure because the other TR also using, no? TR.
No, grade 2 MR is there.
MR. So probably it's
only VSD closure, AST closure, and excision of the subaortic membrane with an alveolar muscle bundle resection.
Resection also. That's also done through the right atrium, transatrial. What is the access for a subpulmonic VSD?
So through pulmonary artery.
It's better to be true because previously all VSDs used to be closed transventricular. What's the problem of transventricular closure?
Post-surgery RV dysfunction.
Yeah, mildly, but not very much. Usually they produce right bundle branch.
Yes.
But transventricular also can produce right bundle branch block. So that's one of the most common rhythm disturbance after closure of the VSD.
Yes,
The literature says after a right ventricular opening and closure of the VSD, 90% of them may have a right bundle branch block. Where even transatrial, about 40 to 50% of them may have a right bundle branch. But what is the most dangerous thing? Rhythm disturbance.
Yes, sir.
Surgical closure. It's a complete heart block.
Yes.
Yes. What incidence of complete heart block in Narayanakriti area?
So less than 1%.
Yeah, less than 1%. Which is less than a complete heart block. Ventricular rhythm disturbance in case of VSD closure.
Sorry, sir.
I said most of them will have a right
Right
bundle
bundle
branch,
branch.
which is not a very hemodynamically significant.
Okay.
Some may have a complete heart block. In between, what else can be there?
Left anterior hemiblock.
Very good. LH, left anterior hemiblock. In an ECG, how we can find out whether the left anterior hemiblock?
So that's the QRS is like a W pattern. Anteriorly.
Most of the VSD is a right axis deviation. If it is left anterior hemiblock, usually they got a left axis deviation. So if you follow a patient before surgery at the right axis deviation, after operation for a left axis deviation, there's a clear evidence that they got a left anterior hemiblock.
Yes, sir.
Without all the cardiologist details of how to find out, but this is a rough and ready method of finding out whether it's a left anterior hemiblock. Patient with a left anterior hemiblock has to be followed up because some of them may develop later on complete heart block.
Okay, sir.
The technique, I'm sure you have seen in the case of transit VSD, what patch we use, what are sutures we use, a continuous suture, interrupted suture, some continuous, some interrupted. All those techniques we have described many times.
Yes, sir.
What's now normally done in this hospital is a continuous suture.
Continuous suture.
And then they usually ask you what's the course of the bundle in case of VSD. And in most perimembranous VSD, the bundle courses through which region of the ventricular septum?
So posterior inferior.
Posterior inferior. Not at the apex of the ventricular septum, but more towards the left side. Okay? That's why you take suture slightly away from the apex and on the right ventricular aspect, because the bundle goes to the left ventricular side of that. What's the course of bundle in AV canal type of VSD?
So it is displaced anteriorly.
Exactly opposite, anterior superiorly. This is the posterior inferior part. That's why you have to be careful when you go canal type of VSD.
Yes.
What other methods are there to close VSD?
So device closure.
Device closure. When do you do that? What are the indications? What are the contraindications of device closure?
So, a moderate to small sized VSTs with a good surrounding margins. And the VST should not be near the conduction area, like perimembranous inlet VSTs are avoided. And the VST should be at least 1 centimeter away from the aortic valve.
Normally, the surgeons answer it. The best VST is they close by catheter.
Muscular VST.
Muscular VST.
Oh.
And then number 2 is indication is a post-operative recurrent VSD, where the VSD is recurrent in the lower part, but near the muscular end. Okay. That is class 1 indication, muscular VSD and recurrent VSD at the lower part of the patch. Class 1 indication. Class 2A indication nowadays, the cardiologists try to close everything catheter runs to the injection, perimembranous VSD, with a margin from the aortic valve about 5 millimeter. 1 centimeter is you never get, So 5 millimeter away from the aortic valve is the margin of the VSD. That can be closed by a device, a special device. But there is some contraindications of doing that. The presence of air, the presence of MR, the left bundle branch block is already there. Those are the contraindications to do a transcatheter device. It should be definite muscular VSD class 1 and the recurrent VSD in the lower part of the class 1. The others are class 2 here. What the weight of the child or device close?
The device size, sir.
What is the size of the patient? The device goes through the femoral vein. Even then, they say it should be done in children more than 8 kilograms. Last time when we described the ASD, I said in ASD should be done only in children above 15 kilograms. That's because the pure size of the ASD device is a fan cell type, it's a huge structure sitting inside the eye. So, general understanding is ASD transcatheter closure in a child above 8, satisfying all the other conditions. ASD more than 15. What are the other complications? If it's a large VSD, what happens? What are the post-operative complications?
Surgical complications.
No, post-operative.
Right bundle branch block.
I know that. It doesn't mean. Pulmonary hypertensive crisis is the one that we have described many times. They should know how to manage that.
Yes, sir.
The first is to hyperventilate, to get PCO to 30 or something. Then you know the nitric oxide or something. I'm sure you know.
Yes, sir. Sedation.
Yeah. Is that the type of questions you should expect in an exam? Any other doubt? Anybody? Now then the other is hybrid closure.
Yes, a per ventricular device closure. Per ventricular device closure.
Yeah. Usually done in a hybrid theater. That also the indication is, I think, is same as a muscular VSD and recurrent VSDs are the best for a hybrid closure.
Yes, sir.
Any questions? Do they do hybrid closure here?
Yes, sir, they do.
What are the indications of closing a small VSD?
Indication, no. Aortic regurgitation, aortic valve prolapse.
Yeah. One more. The patient had a bacterial endocarditis before. It's a usual indication. Normally, of course, there are a lot of people nowadays close all small VSDs to prevent bacterial endocarditis, but many surgeons don't accept that. But if the patient has already a bacterial endocarditis, when it's healed, it's better to close such a VSD. Okay.
So if it is a healed endocarditis, the vegetations are closing the VSD, should we operate?
No, I don't think it ever closes fully. So that's in the textbook described as the third or fourth cause for a perimembranous VSD, but that's not correct. But if the patient is already a endocarditis, there's a chance of recurrence of VSD. So an episode of endocarditis in a small VSD is an indication to close it electively.
Yes, sir.
Any other doubt? The mortality depends on the vascular resistance. Usually it's less than 1%. Okay.
Yes, sir. So why autologous treated pericardium is preferred over Dacron patch?
Which one?
Treated pericardium preferred over Dacron patch.
Because chance of infection in a synthetic, if you use the Dacron or Cortex, the chance of infection is much more. And it cannot be eradicated by medicine. So that's why I think Narayana Hridayalaya over a long time ago changed into, isn't it? Or do they still use some? Do they use treated pericardium or do they use Dacron patch?
Treated pericardium, most of them.
No. That's because of the less chance of infection in such cases. And it's treated because it's easy to
Manipulate.
show it, it's slightly stiffer and easy to close it by showing it to the ventricular septum. Okay, thank you very much. If there's no doubt, thank you very much.
Thank you, sir.
Bye. Thank you.